My proposal is to create a satellite chest wall clinic in the north of Scotland to assess the benefits in patients' chest wall lift, with the focus on pectus excavatum and the physiotherapy treatment of a vacuum bell. My aim is to increase the chest wall lift in paediatric patients part of the Scottish National Chest Wall Service by 20% in 12 months by having a satellite clinic in the north of Scotland. By doing this, I hope to improve patient satisfaction with physiotherapy chest wall intervention. These are my key stakeholders below. The Scottish National Chest Wall Service is based in Glasgow's Royal Hospital for Sick Children and is the only location in Scotland. 1 in 400 children across the UK have a pectus excavatum. The NHS 2025 said they aim to provide an MDT holistic approach for those with a chest wall deformity. Please pause and read what a vacuum bell is. Currently, the Scottish National Chest Wall Service process involves a triage virtual appointment. This is to assess if a patient is suitable for intervention. This is then followed by an in-person visit to the Glasgow Clinic for a physical assessment of the chest wall movement and the depth of the deformity. Next is the vacuum bell fitting. The vacuum bell comes in 3 sizes and is based off the size of the patient's chest. Once it fits, the patient is shown how much pressure is needed to be applied using the handheld pump. According to Hecker and Mayer, the pressure should be approximately 15% below atmospheric. This stage should be done in person, however, there are barriers that can get in the way of this. For example, some families are unable to travel to Glasgow, they have other children, they have work, school, etc. Therefore, this section can be done on a virtual call. Why does this service need improvement? I believe this service needs improvement as when I was in placement, I noticed a common problem with patients who had been doing the video calls. They had not been seeing results, and this was mainly due to the incorrect positioning and not enough pressure being applied. This indicated that there is room for development in how the service is delivered, as it is near impossible for a physiotherapist to fully assess how much pressure a patient is applying over a video call. Why change from virtual? Reports have found that patients can feel less confident to describe their symptoms over a video call. Donaghy et al. 2019 found that virtual appointments can also be difficult with children, as there can be a difficulty with communication and attention. Technical challenges can also negatively impact intervention effectiveness, the flow of the appointment, and the satisfaction of both patients and clinicians. Although there is a lot of literature to suggest that virtual appointments are beneficial, these are focused on adults and MSK physiotherapy. There lacks evidence which suggests that virtual appointments can be good for other areas of physiotherapy or for children. The quality improvement can be defined as a combined effort of healthcare professionals, patients, families, etc., to make changes that will result in better patient outcomes. PDSS cycle is a 4-part model to improve a service or process. It involves prediction in the plan phase, implementation in the do phase, data analysis in the study phase, and whether the action should be adapted, adopted, or abandoned in the act phase, according to Christoph 2018. According to the NHS England 2023, the PDSS cycle is beneficial as it allows to implement a proposal on a small scale. This allows stakeholders to see if the proposed change will benefit them, which is why I have chosen this for my proposal. Below is my PDSS plan. Some key facts in this is, in my plan section, I plan to establish a location, see which patients or home addresses will be suitable, and collect some in-person clinic stats. For my do phase, I plan to carry out my plan. Gather continuous chest wall lift results over the 12 months in the in-person clinic, and also gather feedback and information from the patients and families on what they liked about the clinic. In the study phase, I will analyse this feedback, see what worked well and what didn't work well, and see what outcomes there were. See what outcomes achieved and see was there any unexpected outcomes. In the act phase, I will confer with my stakeholders and see if a permanent clinic should be added. I will also assess with my clinicians and see how they found the process. Possible conflicts include funding. The NHS may be reluctant to fund another clinic as this will cost more money and in the short term. However, we can describe to them that this clinic will hopefully reduce the amount of time the service user is in the service, therefore reduce wait times for waitlisted patients. Staffing, there may be a limitation to staff up north with the knowledge of the service. Therefore, we can provide an in-service so they are fully equipped and know what to do. These are the different outcome measures. The main one currently used in the service is to measure the pectus excavatum with a ruler. I will be comparing and contrasting results from before in the virtual clinic and after the satellite clinic was put in place. These are my references for my proposal. Thank you for listening.